of time, we might get cracking. So, hi everyone. Welcome to the second virtual ward round today on infectious diseases. For those of you whom I haven't met yet, my name is Victor and I'm currently working as a junior doctor at the Royal Melbourne Hospital. In these virtual ward rounds, I'll endeavour to provide some practical insight into how theory learnt from medical textbooks can be used to solve real-world clinical problems. And like last time, I'll take you guys through three semi-interesting cases and try to use them as a stimulus to talk about some important clinical concepts pertinent to any ID rotation. So, as you're no doubt aware, the Virtual Ward Round series is brought to you by Teaching for Impact, a not-for-profit organisation with a mission to use education as a weapon to create meaningful social change. This year, all of our medicine lectures are being run as fundraising events for the Asylum Seeker Resource Centre, the ASRC, who are the largest independent human rights organisation for people seeking asylum in Australia. We share ASRC's belief that all asylum seekers deserve protection, respect and a chance to rebuild their lives, and invite medical students across the state to join us in our campaign to make a meaningful contribution towards this worthy cause. For those of you who are interested in keeping abreast of the tutorials and lectures that our dedicated TFI medicine team has to offer, again, please scan the QR code on the right. As mentioned last time, my intention is to keep these sessions relatively informal. So at certain points, I'll put some questions to the floor, and I would love it if you could all contribute answers to the online chat, or better yet, if you're up for it, unmute and share your thoughts with the group. And I guess, you know, learning is always more fun and effective as a dialogue rather than a monologue. So without further ado, let's get cracking. I might just admit some new people who just joined us. All right. So let's begin with a quick review of how bacteria are classified. Based on how bacteria stain on application of the Gram stain, we can divide bacteria into gram-positive bacteria and gram-negative bacteria. And as you all should know, gram-positive and gram-negative bacteria stain differently because they have different cell walls. Suppose you were trapped inside the cytoplasm of a bacterium and were trying to get out. If you were trapped inside of a gram-positive bacteria, you will need to traverse the plasma membrane, firstly, and then a thick peptidoglycan layer in order to get out. Whereas if you were trapped inside of a gram-negative bacteria, you will need to traverse the plasma membrane, which we also call the inner membrane, and then a thin peptidoglycan layer, and then an outer membrane in order to get out. And the space between the inner membrane and the outer membrane is what we call the periplasmic space. And it is in this periplasmic space that the thin peptidoglycan layer floats. So Gram stain, you know, it's a process that involves first applying a primary stain called crystal violet, which is essentially a blue or purpley stain to the bacteria. Then you wash it out with ethanol, and then you apply a counter stain, often safranin, which is a pink stain. Because gram-positive bacteria have a thick peptidoglycan layer, they tend to retain the crystal violet, which doesn't get washed out by the ethanol. And so gram-positive bacteria stain purple on gram stain. In contrast, gram-negative bacteria only have a thin peptidoglycan layer, and hence they don't tend to hold on to the crystal violet as well. And so the crystal violet gets washed away with the ethanol. And on application of the counter stain, the gram-negative bacteria then stain pink. So hopefully that should be all revision for everyone on this call. Now, so on gram stain, we can divide bacteria into gram-positive and gram-negative. And then based on morphology, we can further divide gram-positive and gram-negative bacteria into cocci, which are round, or bacilli, which are rod-shaped. And so let's focus on the gram-positive cocci first. So gram-positive cocci can be further divided into catalase positive or catalase negative. Catalase positive bacteria we call Staphylococcus, and they tend to grow in clusters. So they can replicate in every direction in three-dimensional space, and so tend to form these great light clusters. Catalase negative bacteria we call streptococci or enterococci, and they tend to grow in only 2 dimensions. So they grow in either in pairs or in chains. And I guess hopefully you learnt this at some point throughout your med school career. But one way to distinguish between staphylococci and streptococci is based on whether they grow in clusters or in pairs or chains. So we'll focus on Staphylococcus first. So Staphylococci can be further divided into coagulase positive and coagulase negative staph. So coagulase positive staph essentially means Staph aureus. And does anyone know what Staph aureus causes? What kinds of infections Staph aureus causes? Again, feel free to contribute to the chat or just unmute and share your thoughts. Yep, cellulitis. Any other infections that Staph aureus specifically is associated with? Infective endocarditis, good. Yep, septicemia, line infections, cool. So yeah, they can cause a number of different infections. Most commonly, cellulitis, infective endocarditis, joint infections, and they tend to form sort of walled off bits of pus, which we call abscesses. And so they're quite a common cause for epidural abscesses as well. So coagulase positive means Staph aureus. Coagulase negative, there are a number of coagulase negative staph. Commonly Staph epidermidis is a common coagulase negative staph, usually a normal flora of skin, but can cause bacteremia. And the other common one that you will see is Staph saprophyticus, which does anyone know why Staph saprophyticus is clinically significant, or what is it known to cause? Yeah, good. It's actually the second most common cause of uncomplicated UTI in young women, behind E. coli. So it's usually a normal flora of the female genital tract and perineum, and is often associated with UTI. Great. Okay. So let's now turn to strep and enterococci. So strep can be divided into 3 types based on their capacity to hemolyze red blood cells. So alpha hemolytic strep, beta hemolytic strep, and gamma hemolytic strep. And alpha hemolytic strep causes partial hemolysis and include things like strep pneumonia, which is, I guess it's famous for being one of the 3 encapsulated organisms that you need to vaccinate for after splenectomy. Do you guys know the other 2?
And Neisseria meningitidis and Haemophilus influenzae. Yeah,
great. So yeah, 3 encapsulated organisms. If you have a splenectomy, you're susceptible to infections by these 3 encapsulated organisms. So we tend to vaccinate patients post-splenectomy against strep pneumoniae, Neisseria meningitidis, and HIB, Haemophilus influenzae type B. And the other important alpha hemolytic strep is Viridans strep. And there are many who belong to this group. Do you guys know why Viridans strep is clinically significant to know about?
I think it causes subacute infective endocarditis.
Yeah, absolutely. And what causes acute infective endocarditis usually?
I think it's usually Staph aureus.
Yeah. So Staph aureus, number one cause for acute infective endocarditis. Subacute, which means really developing over weeks to months. Most common cause will be Viridans strep, and we'll go into this in a little more detail later on. Cool. So going to the beta hemolytic strep. So beta hemolytic strep cause complete hemolysis. And can be divided into group A, group B, there's also group C, group G, et cetera, et cetera. But group A strep is also called Strep pyogenes, and this is a bug that all of you should be familiar with. What does Strep pyogenes cause, or group A strep cause? Tonsillitis, cool. Yeah, absolutely. Its claim to fame is that yep, it can cause a strep throat, but then subsequent to that, you can get antibodies developing against the M protein antigen of Strep pyogenes, which cross reacts with a cardiac antigen. And so you get this really autoimmune reaction post a strep throat, which we call rheumatic fever, and later rheumatic heart disease. And yes, it can also affect the kidneys as well, causing a glomerulonephritis. Cool, so that's group A strep. Group B strep is also called Strep agalactiae. Do you guys know why group B strep is clinically significant? Yeah, absolutely. For those who've done their peds or women's rotation, group B strep comes up quite a bit. Is an important cause of pneumonia, meningitis, sepsis, mainly in neonates. And the final type of streptococcus is gamma hemolytic strep. Bit of a misnomer because gamma hemolytic strep causes no hemolysis. And there's one particular gamma hemolytic strep that you need to know about, which is Strep bovis. And now they've changed the name of Strep bovis actually to Strep gallolyticus. But I think in most of the literature, you'd still find Strep bovis being used. Why Strep bovis clinically significant? Colorectal cancer, fantastic. Yeah. So associated with colorectal cancer, it's also an important cause of subacute infective endocarditis, as we'll go into a little later on. But the thing to remember about Strep bovis or Strep gallolyticus is that it's associated with colorectal cancer. And so if you have a patient that develops a Strep bovis bacteremia, you should reflexively put through a referral for a colonoscopy to exclude colorectal cancer, because these patients are at high risk of developing or having concurrent colorectal cancer. Cool. So that's strep. Now with Enterococcus, so Enterococcus is a very similar organism to strep. Two main species that you need to know about, Enterococcus faecalis and Enterococcus faecium. So both of these species are normal colonic flora. Both of them are penicillin G resistant and tend to cause UTIs mainly, but can also cause biliary tract infections, and as we would discuss later on, subacute infective endocarditis as well. Now, have you guys been taught the difference between E. faecalis and E. faecium? Which one do we worry about more? And there are also important differences to how we treat E. faecalis versus E. faecium. So so essentially the difference between E. faecalis and E. faecium is that faecalis is sensitive to amoxicillin, so you can treat with IV amoxicillin, E. faecalis bacteremia. But E. faecium is resistant to amoxicillin. And so we usually treat E. faecium with vancomycin. So E. faecium is the more resistant bug that usually is resistant to your standard penicillins, and you need to treat using a glycopeptide like vancomycin. So the way that I remember this is E. faecalis has 2 A's, so it's ampicillin sensitive. Faecium only has 1 A, and so isn't sensitive to amoxicillin. We need to use vancomycin. So important difference to bear in mind. So that's the gram-positive cocci. So just to summarize, 2 main types of gram-positive cocci distinguished by the catalase test. So catalase positive means Staph. Catalase negative means Strep or Enterococcus. Staph can be further divided into coagulase positive Staph, which is Staph aureus, and coagulase negative Staph, of which there are a host, but the important ones are Staph epidermidis, which is a normal skin flora, and Staph saprophyticus, which is an important cause of UTI, especially in young women. In terms of Strep usually distinguished based on how they hemolyze. So alpha hemolytic Strep, there are 2 that are important: Strep pneumoniae and viridans Strep. Beta hemolytic, divided into Group A, Group B, Group C, Group G. But Group A and Group B are the ones to remember. And remember, gamma hemolytic Strep, only really one that's important: Strep bovis, which is associated with colorectal cancer. Enterococcus, there are only 2 species that you need to know about: faecalis and faecium. Know the difference between the 2 and how we treat it. Faecalis has 2 A's and therefore is amoxicillin sensitive. Faecium has only 1 A and so is resistant to amoxicillin. We need to use vancomycin. Let's now talk about the gram-positive bacilli, so the gram-positive rods. And I think for those of you who tuned into the first virtual Ward Round series, I sort of alluded to this last time. So there are only really 5 genuses of gram-positive bacilli that you need to know about, and I remember it using the mnemonic A, B, C, D, L. So A stands for actinomyces, B stands for bacillus, C stands for clostridium, D stands for diphtheria, and L stands for listeria. Pop quiz, there are 2 important species of bacillus that you should know. Can anyone offer any species of bacillus that are clinically important and sort of talk about why that particular species is clinically significant?
Is it pertussis or?
No, pertussis is a different organism. So bacillus, there are really, only 2 that you need to know about that are clinically significant. One is Bacillus cereus. So I think the classic teaching is that this is the bug that's associated with fried rice. So it causes food poisoning. They generate spores which survive in reheated fried rice. The spores are ingested, the spores then germinate. Bacillus cereus produces an enterotoxin, which then causes diarrhea and vomiting within hours. So it's an important cause of food poisoning associated with fried rice. Bacillus anthracis is the second one that you should know about. It produces an exotoxin called anthrax toxin. And causes a disease called anthrax. And there have been sort of terrorist attacks on American presidents where some Bacillus anthracis was put inside of an envelope. Anthrax can be a life-threatening disease when inhaled. So C stands for Clostridium. There are maybe 4 main species of Clostridium that are clinically significant. Anyone know any? C. difficile, cool. We talked about that at length last time. So important cause of C. difficile infection. Important antibiotic associated diarrhea. Clostridium botulinum, as the name suggests, causes produces this heat labile toxin that inhibits acetylcholine release at the neuromuscular junction, causing botulism. Botox is often used for therapeutic purposes, even in hospital as well. I've not really recently, but had a patient who came in with a stroke and had quite significant spasticity of the upper limbs, of the right upper limb following a left MCA stroke, and the neuro fellow helped to administer some Botox to try to relieve that spasticity. So it is used for therapeutic purposes. And someone mentioned perfringens. So what does this cause? Yep, so it causes gas gangrene. And the other one is, tetani, which causes tetanus. Cool, D stands for diphtheria. So the actual organism doesn't start with D. Diphtheria is caused by Carinibacterium diphtheriae. But the disease is called diphtheria, and L stands for listeria. And the most important one is Listeria monocytogenes. And the reason why you need to know this is that it is a not so rare cause of bacterial meningitis in immunocompromised patients, and also in those in the extremes of age, so neonates and older adults. So only 5 clinically significant gram-positive bacilli. Let's proceed to the gram-negative cocci. So there's only one really genus that you need to know about, and that's Neisseria. And there are only 2 species of Neisseria that you really need to know about, one of which has already been mentioned. So Neisseria meningitidis, the second of the encapsulated organisms that we need to vaccinate for post-splenectomy. And then there's also Neisseria gonorrhea, which causes gonorrhea. Cool. And then, so the way that I remember this is that, so you remember the gram-positive cocci, you remember the gram-positive bacilli, you remember the 1 gram-negative coccus, and then the rest are gram-negative bacilli. So, I mean, if in doubt, if you're asked on the ward round, what is this a gram-positive, gram-negative, or is it a rod? Is it a coccus? If in doubt, most pathogenic organisms are actually gram-negative bacilli or gram-negative rods. Under this category includes, all the sort of most common bugs that cause diarrhea or GIT infections, such as E. coli, Campylobacter, Salmonella, Shigella, Vibrio cholerae, Yersinia pestis, et cetera. Some common respiratory bugs as well, Haemophilus influenzae, which is our third sort of encapsulated organism that we need to vaccinate for post-splenectomy. Legionella pneumophila, important cause of atypical pneumoniae. Klebsiella pneumoniae, Bordetella pertussis, which was mentioned previously. I've put them down there, Hackett organisms. Does anyone know what Hackett organisms are?
I know it's just something related to endocarditis, but yeah, that's about it.
Yeah. I'm getting some questions about the resolution of the screen. I don't have a easy fix for that. I can circulate the slides at the end of the lecture, and we'll try to curate the video that goes up on YouTube later on to try to make it higher resolution. But unfortunately, I don't have a quick solution to that at the moment. So yes, Hackett organisms is a rare cause of infective endocarditis. Causes about 3% of infective endocarditis. For Browning points,
So just like, I know she's clearly incredibly smart, but like, I wouldn't want to get a question wrong.
No. I think she should be okay.
I think someone has forgotten to unmute. Yeah, thank you. Cheers. Great. So yeah, HACEC, for brownie points, does anyone know what HACEC stands for? Oh, not. Oh, well, yeah, it stands for Haemophilus. Yep, close. Yep. Aggregatibacter, and C stands for Cardiobacterium, E stands for Eichinella, and K stands for Kingella. So we'll touch on this in more detail later on again, but HACEC organisms associate with infective endocarditis, causes around 3% of infective endocarditis cases. Pseudomonas aeruginosa, you will see this organism again and again and again. It is classically associated with antibiotic resistance. So it's intrinsically resistant to a lot of the common antibiotics that we use in hospital. It's usually, we usually, for Pseudomonas coverage, the go-to antibiotic is IV tazocin. And can someone remind me the two drugs that make up tazocin? Yeah, piperacillin and tazobactam. So great, cool. And I've put in there escapum organisms. So escapum is another acronym. E stands for Enterobacter, S stands for Serratia, C stands for Citrobacter, A Aeromonas, P Proteus. Proteus mirabilis is an important cause of UTIs and is commonly associated with struvite stones. I have a patient on the ward at the moment with Proteus mirabilis urosepsis and complicated by a staghorn calculus. Had to have a nephrostomy tube inserted. So important organism to know. The other P stands for Providentia and M stands for Morganelli. So the reason why these escapum organisms are important to know is that they need to be treated with meropenem. They're also intrinsically resistant to a lot of the common antibiotics that we use on the ward. Cool. Okay, so that's a Cook's tour through bacteria, and we'll revisit a lot of these concepts as we progress through this ward round. So the first patient that we're going to see is a 55-year-old female who's an active IVDU, admitted with fever of unknown origin. Blood cultures were taken, and thankfully prior to antibiotic commencement, and the patient was found to have Staph aureus on blood cultures. Past medical history is significant for untreated hepatitis C and psoriasis. Patient's not on any regular medications, and she's from home with her husband, is usually a heavy smoker and a heavy alcohol user as well. So not an uncommon clinical scenario on the ID ward. Here are her bloods. So a bit anemic, normocytic anemia. Platelets a little low, but that's neither here nor there. White cells are not incredibly elevated, but they are elevated. So there's a bit of neutrophilia there. Potassium is a bit low, again, neither here nor there. Urea is a bit up, so a bit of renal impairment. And LFTs are a bit off as well, unsurprisingly so, given she has hepatitis C infection that has been untreated. Fibrinogen is a bit elevated. What are people's interpretation of that? What do you guys make of elevated fibrinogen? So fibrinogen is an acute phase reactant. So it's so are platelets really. So sometimes in an acute inflammatory state like an acute infection, those markers can go up. So again, elevated fibrinogen just tells us that the body's inflamed. Cool. Okay. So here are the blood cultures. So blood cultures positive only in the aerobic bottle. But were positive on 2 sets of blood cultures taken prior to antibiotic commencement, and time to positivity was 21 hours. It's fine, and strong warnings here that Staph aureus is never a skin contaminant. When you find Staph aureus in the blood, you need to treat it seriously. You need to consult ID, and you need to get this patient started on IV antibiotics. It's not methicillin resistant, which has important implications for treatment. And we'll talk about the difference between methicillin resistant and methicillin sensitive Staph aureus a little later on. So Staph aureus, we already sort of like primed this discussion with our flowchart of how we classify bacteria. So it's a gram-positive coccus, it's catalase positive, coagulase positive, and unlike streptococcus and enterococcus, tends to grow in clusters. It's a normal flora. It normally colonizes sort of the nares, the ears, the axilla, and the groin. But the reason why Staph aureus in the blood is bad is because Staph aureus bacteremia has the highest 90-day mortality of any bloodstream infection. I mean, often we worry about things like meningococcemia. So having Neisseria meningitidis in the blood, we think of that as being bad. Staph aureus bacteremia has a 90-day mortality that's 3 to 4 times that of the mortality associated with meningococcemia. So it's one of the most important bloodstream infections, and probably if you're doing an ID rotation, it's impossible to get through an ID rotation without having seen at least 1 case of Staph aureus bacteremia. It's a very, probably one of the most common presentations, and one of the most common clinical scenarios that you'll see on ID. Now, Staph aureus has a number of virulence factors. One of the more interesting ones is protein A. And I don't expect you guys to know this, but do you guys know how protein A works to evade the immune system? I'm hoping there are a couple on this call that did an undergrad degree in microbiology or immunology. Anyone heard of protein A? Yeah, absolutely. Well done, Josh. So yeah, it's actually a curious virulence factor. So usually we have, we develop antibodies that bind to antigens on the surface, and that does one of many things. So if it's IgG or IgM that binds to the pathogen surface, it can activate complement. So the classic pathway of complement activation. So we get C1q binding to the FC portion of the IgG antibody that's bound to the pathogen surface, and that initiates the classical pathway of complement activation. And as you guys know, the terminal sort of event in complement activation is the destruction of the pathogen, the activation of an inflammatory response and the destruction of the pathogen with the formation of the MAC complex. IgG antibodies, bound to antigens on the pathogen surface, serve as an instigator of complement activation. It does have a second role, and this is the role that Josh mentioned. It can act as opsonins, and opsonins are these things that make foreign microbes like bacteria more attractive to phagocytes. So what happens is that the antibody sort of binds to the pathogen surface and exposing its FC portion, and then phagocytes then have a receptor for the that recognizes the FC portion of the antibody. They bind and then phagocytose the pathogen. So what protein A does, so Staph aureus, so I have a sort of a schematic of a Staph aureus bacteremia here. They intentionally express this protein A on their surface. And the protein A binds to the FC portion of these IgG antibodies that have been raised against the bacteria. And so now the antibody is actually the other way around. So it's now bound at its FC end, and it's exposing its FAB end to the blood. It can no longer activate, the classical pathway of complement, and it can no longer act as an opsonin to facilitate phagocytosis. So that's one of the main virulence factors for Staph aureus. So Staph aureus bacteria, so as we said, it's a colonizer of the nares, the ears, the axilla, and the groin. So how does Staph aureus actually get from there into the bloodstream? So there are two main portals of entry. So one is it can get in through the skin and soft tissue. If someone mentioned before that Staph aureus is an important cause of cellulitis, indeed it is. And sometimes it can get in through the skin. When it infects the skin, causes a bit of cellulitis, and then it invades deeper. But the second common portal of entry is an indwelling prosthetic device, such as an intravascular catheter, orthopedic hardware if the patient has had like a total knee replacement or whatever, cardiac devices, permanent pacemakers that have been inserted for things like tachybrady syndrome. Yeah, and of course, in an active IVDU, which is what we have with our patient, often Staph aureus can be introduced directly into the vein through the needle that the patient used to shoot up. Importantly, once the once Staph aureus gets into the blood, it can then seed into different organs to cause metastatic infection. And as I alluded to earlier in this talk, Staph aureus likes to form these walled off bits of pus, which we call an abscess. So it seeds into the organs and then often causes an abscess formation. So a couple of organs that it typically seeds to, so bone and joints, resulting in osteomyelitis, discitis, or an epidural abscess. And sometimes an epidural abscess can cause, cauda equina, which is a neurosurgical emergency. It can seed into heart valves, so latch onto heart valves and cause an infective endocarditis, and that typically presents with a protracted fever and sweats, and we'll talk about infective endocarditis in more detail later. It can seed into the spleen, resulting in splenic infarcts, which typically presents as left upper quadrant pain. It can seed into the kidneys and the psoas muscle, causing renal infarctions or psoas abscess, which classically presents as costovertebral angle tenderness, and it can even seed into the brain, causing cerebral infection and infarction, which classically presents with headache or a stroke-like kind of presentation. Got a question from Han Yi. Could you quickly clarify what you said before about why a positive Staph aureus blood culture is unlikely to be due to sample contamination? So I guess the point that I was trying to make is that detecting Staph aureus in the blood is always significant until convincingly proven otherwise. So you will always treat, if you find that a blood culture flags positive for Staph aureus, you'll always treat that. And you will never assume that it can potentially be a skin contaminant, but you'll always treat it as though it wouldn't, as though it wasn't. And the reason is because it's associated with the highest 90-day mortality of any bloodstream infection. Yes, potentially. Yes, even if the patient looks clinically well. But you know, there's obviously a reason why you took the blood culture. So I guess, you know, if the patient was actually, you know, clinically perfect, you wouldn't go stabbing them for a set of blood cultures. So it's usually in the context of, you know, fever of unclear etiology, you know, raised inflammatory markers of unclear cause that you do blood cultures. And yes, if it comes back as Staph aureus positive, you'll always treat it until you can convincingly show that it's a skin contaminant. Cool. Okay. So, so why was all of that knowledge helpful or useful in the clinical context? Because knowing all of that informs the approach that we take to a patient presenting with Staph aureus bacteremia. You know, the first step, you know, as with any clinical presentation, is always to take a history. And I guess the goal of taking a history from a patient presenting with Staph aureus bacteremia is to identify possible portals of entry. In this case, you know, that there isn't, you know, one, you know, likely, you know, portal of entry, which is, you know, patient shooting up from a groin or from their arm, and introducing bacteria that way. But you need to look for other possible portals of entry. You know, the patient might have you know, a cellulitis in their lower limbs that you wouldn't otherwise identify if you don't, you know, properly, you know, examine the patient. You know, that's one goal. The second goal is to identify symptoms associated with metastatic infection. So bearing in mind, you know, all the, you know, common organs that Staph aureus can potentially see to, you know, you need to ask about things like, you know, bone pain, joint pain, you know, abdominal pain, you know, headaches, et cetera, neurological symptoms, et cetera, to try to, you know, assess for the likelihood of metastatic infection. The second step is to perform the exam, and the goal is much the same, to identify, you know, portals of entry and signs associated with metastatic infection. Then, like, for example, if the patient reports, you know, back pain, has spinal tenderness and, you know, cauda equina symptoms on examination, then you need to seriously consider vertebral, you know, osteomyelitis, discitis, epidural abscess. The patient has, you know, shows peripheral stigmata or effective endocarditis. You know, you're hearing a new valvular, you know, regurgitation or auscultation of the patient's precordium, presents with some signs of heart failure, has some peripheral edema, sacral edema, elevated JVP, etc. Then you need to consider infective endocarditis. And just while we're talking about this, can someone remind me, there are 4 peripheral stigmata of infective endocarditis that we typically look for on examination. Do you guys know what they are? Osler nodes, Janeway lesions, Roth spots, and splinter hemorrhages. Fantastic. For brownie points, what's the difference between a Janeway lesion and an Osler node? And you probably need to unmute and share your thoughts for this one.
Osler nodes are tender, right?
Osler nodes are tender. Yep. So, you know, Jane, no pain. So Janeway lesions are painless.
Victor, can I just ask a quick question?
Absolutely.
In your experience, what have you seen any of these signs? Do they present commonly?
Absolutely. I have a patient sitting on my ward at the moment with Janeway lesions.
Thank you.
I haven't seen Roth spots because I don't really do fundoscopy on the ward. But splinter hemorrhages, yes, I've seen, although splinter hemorrhages is a non-specific sign. It's not really specific to infective endocarditis. Janeway lesions I've seen. I don't think I've seen Osler nodes, and I don't think I've seen Roth spots. The other thing to remember about the difference between Janeway lesions and Osler nodes, yes, Janeway lesions are painless, Osler nodes are painful. They're both erythematous lesions. Commonly, Janeway lesions are flat and they occur on the palms and the soles, and they're caused by septic embolization from an infected valve. Whereas Osler nodes is slightly different. It's not it's painful, it's red, it's commonly raised. You see it on the pads of the fingers, and they're not caused by septic embolization. They're caused by immune complex deposition. And same deal with Ross spots as well. It's a immunological phenomena where you find retinal hemorrhages with these pale centers on fundoscopy. It's due to immune complex deposition rather than septic embolization. So it's an immunological phenomena rather than a vascular phenomena. And that gets important when we talk about the Duke's criteria later on. So that's as an aside. Obviously, if the patient reports left upper quadrant pain, is tender in the left upper quadrant area, you need to think about splenic infarcts, possible metastatic infection to the spleen. If the patient has some costovertebral angle tenderness, need to seriously think about renal infarcts and psoas abscesses, and headaches, neurological symptoms, think cerebral metastasis. You do your history, you do your examination. Commonly, then you make your referrals and then you order your investigations. Now, it's important, it's absolutely essential for all patients with Staph aureus bacteremia to refer to ID. If you're on the Gen Med ward, which I'm on at the moment, not that Gen Med clinicians can't deal with Staph aureus bacteremia, but there have been studies that have been shown that bedside ID consultation has been associated with a significantly lower 90-day mortality. 9% mortality if you involve ID, 29% mortality if you don't involve ID. A very statistically and clinically significant result. So ID referral is a must. Often, depending on, what kind of metastatic infections that the patient has, you might also need to involve cardiology for organization of echocardiograms, and we'll talk about that later. Potentially cardiothoracics, because if you have a massive massive on the mitral valve causing mitral valve dysfunction, so severe mitral regurgitation, and patients have developed heart failure from that, that's often an indication for urgent valvular surgery, and just treating the patient with antibiotics is not going to cut it for the damage that the infective endocarditis has done. So often you need to involve cardiothoracics as well. And if the patient is complaining of back pain, obviously you'll order an MRI brain, but often you'll also do an early referral for to a neurosurgeon for their assessment. Cool. So in terms of investigations, your investigations are like always guided by what you find on history and examinations. So in our case, we've already taken 2 sets of blood cultures prior to antibiotic commencement. It's common practice in patients who have Staph aureus bacteremia to repeat the blood cultures, every day, every 1 to 2 days until clearance is demonstrated. And I think one thing that you need to remember is that a set of blood cultures can't be said to be definitively negative until they're negative at 72 hours. So you can't just order a blood culture, have the nurses help you collect it, and then the next day on ward round you look up the results and it says negative to date, and you're like, oh, okay, so the blood culture is negative. It can still flag negative until the 72nd hour, I guess. So you need to wait at least 3 days. And if the culture is still negative at 72 hours, then you can rest assured that it's actually negative. Cool. So blood cultures blood cultures every 1 to 2 days until clearance is demonstrated. All patients with Staph aureus bacteremia need an echo to look for the presence of infective endocarditis. Management without an echo is only very rarely considered in a small subset of patients who had their first positive blood culture collected more than 48 hours after hospitalization, without any preceding suspicious febrile illness. In other words, a patient who has nosocomial bacteremia rather than community-acquired Staph aureus bacteremia. You need to ensure that the patient has less than 3 consecutive positive blood cultures, so only a brief duration of bacteremia, and you need to ensure that the patient has no intravascular prosthetic devices. So only in that small subset of patients who meet those 3 criteria would you consider not doing an echo, with the idea being that possibly it's just a skin contaminant. If it's only a brief sort of period of bacteremia and it's nosocomial, it's not community acquired, and the patient isn't at risk of developing a serious infection, doesn't have any intravascular devices, then you can consider. But it's actually quite a brave call to make to have a patient who is bacteremic of Staph aureus and not ordering a toe, not ordering an echo. So, as you know, there are 2 types of echoes. So one is done, with an ultrasound probe transthoracically. So we call them TTE, so transthoracic echoes. The other, you need to sedate the patient and put the ultrasound probe down their esophagus and visualize the heart from the esophagus. We call those TOEs, so transesophageal echoes, and a TOE is substantially more sensitive than a TTE for identification of valvular vegetations. So if you get nothing away from this talk, the one thing that I want you to remember is that you cannot exclude infective endocarditis based on a TTE. Even if the TTE is negative, right? TTE is not that sensitive for infective endocarditis. If the suspicion is still there, you think you're hearing a pansystolic murmur on auscultation, but the TTE is telling you that it's negative, that there's no vegetations, you still need to follow up with a TOE. You can't rule out infective endocarditis using a TTE. Why is it not that sensitive? Because it is really bad at visualizing the left side of the heart. So as you know, the heart is sort of rotated towards the left. So a transthoracic echo only really visualizes the right side of the heart well. In order to visualize the left side of the heart, you really need an ultrasound probe that goes posteriorly. So it goes through the wall of the esophagus and visualizes posteriorly the left side of the heart. And it's left-sided infective endocarditis that is actually serious and that can potentially lead to heart failure. Jason, I don't have that information. Sorry, you probably need to Google that. Not sure of the exact percentage sensitivities. But yeah, so TTE and a TOE, you can't rule out infective endocarditis using a TTE. Now, the type of echo that you order and the urgency with which you order that echo really depends on the patient's risk category. So an urgent TOE is required for patients with a couple of criteria. So one, patients with prosthetic heart valves definitely need an urgent TOE because they're at risk of dying from Staph aureus bacteremia. Patients with cardiac implantable electronic devices definitely need an urgent TOE. Patients with a bicuspid aortic valve or severe mitral annular calcification definitely need an urgent TOE. Those with clinical signs of structural complications from their infective endocarditis, such as heart block. So if you see, a 3rd-degree heart block on ECG, and the patient is bacteremic of Staph aureus, firstly, your clinical suspicion for infective endocarditis should be very high, and you should also be thinking about potential paravalvular extension of infective endocarditis, which might be causing the heart block if the patient hasn't had a history of heart block in the past. And obviously those with signs of heart failure also fit into that category of needing an urgent tow. And those with clinical evidence of cerebral or other visceral infarcts definitely need an urgent tow. So in these situations, if you're on the ward round on an ID ward, you'd be on the phone to the cardiology echo registrar on ward round as you're reviewing the patient at the patient's bedside. It's not something that you can leave, till 3 o'clock in the afternoon. Now, our patient didn't actually, meet any of these criteria. She didn't have any prosthetic heart valves, no cardiac implantable devices, no congenital bicuspid aortic valve, and no heart block on ECG, no heart failure symptoms, and didn't really have any clinical signs of having cerebral or visceral infarcts. But even so, so a tow should still be performed within the first week after onset of bacteremia for those who have their first positive blood culture within 48 hours of admission. In other words, community-acquired bacteremia. Those with persistent bacteremia, so you're still getting positive blood cultures even 72 hours after the index blood culture. Those that are active IVDUs, and this, our patient fits into this, to this category, need a tow within the first week of their admission. Those with possible spinal infections like OM, discitis, epidural abscess, etc., and those with Staph aureus meningitis, which is actually very, very rare. And our patient didn't have this, but our patient is an active IVDU, and had first, positive blood cultures within 48 hours of admission. So would be a candidate for a tow within the first week of their admission. Now, if you have, someone talked about raised Hep C history. What do you mean by, will that make you more suspicious? As in, would that increase their risk of having infective endocarditis? Is that what you mean? So actually, yeah, I was just going to get to this, but the Hep C history, I just meant, was that from IVDU? But you said they do have the history. Yeah. Hep C is a bloodborne virus, as I'm sure all of you are aware. Probably got it from injecting drugs as well. But I think the Hep C history is important to bear in mind for a different reason. And also the LFT derangements on admission are important to bear in mind. The reason is because there are actually, so there are no real absolute contraindications to performing a tow, but there are some relative contraindications which would make any cardiologist performing the tow a bit uncomfortable performing the tow. Do you guys know what 3 contraindications I have in mind? So just remember, to perform a tow, a cardiologist is sedating the patient and putting a ultrasound probe down a patient's throat, essentially, into their esophagus. So not necessarily pulmonary hypertension. Portal hypertension is the one that. So yes, Jason's on the money there. So upper GI bleed, definitely if you have a patient with melena and hematemesis, it's not an absolute contraindication to having a tow, but the cardiologist will be quite I guess reluctant and a bit nervous about thrusting a probe down someone with active upper GI bleeding. The other contraindication is if they have an esophageal tumor. You don't really want to be thrusting a patient down, thrusting an ultrasound probe down a patient's esophagus if there's like a cancer in the esophagus. And the other one is Josh, I'm not sure whether that was a typo and you actually meant portal hypertension. So in patients with cirrhosis, cardiology will be they would be very cautious to exclude portal hypertension before thrusting an ultrasound probe down a patient's esophagus. The reason is because portal hypertension can cause esophageal varices. And if you thrust an ultrasound probe into a patient's esophagus and the patient has, child QC cirrhosis with portal hypertension and massive esophageal varices, you can rupture the varices and the patient can vomit up bucket loads of blood from that. So no absolute contraindications, but those three things, so esophageal varices, esophageal tumor, upper GI bleeding, would make any cardiologist a bit nervous about doing a TOE. So this patient's, you're right, this patient's history of untreated Hep C is quite significant, especially when paired with the LFT derangements that we've seen, the elevated bilirubin, the low albumin, et cetera, we'll be very suspicious in this patient of evidence of cirrhosis. So often, a cardiologist would want you to order a liver ultrasound and speak to gastro and get a formal gastro opinion that this patient doesn't have evidence of portal hypertension on liver ultrasound before they're happy to proceed with the TOE. And this indeed happened with this particular patient. Cool. So that's infective endocarditis and TTE/TOEs. If you have a patient with Staph aureus bacteremia with concurrent back pain, one of the investigations that you need to order quite urgently is an MRI spine, to look for evidence of osteomyelitis, discitis, and epidural abscess. And if you speak to the, if you order it and speak to the radiology registrar and front load your referral with this patient has Staph aureus bacteremia and has back pain with cauda equina symptoms, we want an urgent MRI spine to rule out OM, discitis, epidural abscess. The radiology registrar will be onto it very, very, very quickly. So, in a patient presenting with abdominal pain, costovertebral angle tenderness, you should really order a CT abdomen to look for, splenic infarcts, renal infarcts, psoas abscesses, and other possible intra-abdominal sites of infection. And patients complaining of headaches should really have an MRI brain as well to look for cerebral infections. So this brings us to management of Staph aureus bacteremia. It consists of two components. So one, and perhaps this is the most important, source control. You need to identify what's seeding Staph aureus into the blood and remove it as quickly as possible. And the second component is obviously antibiotic therapy. Source control means removing anything that could potentially be an ongoing source for infection. So this includes, peripheral cannulas, short-term central lines, long-term venous access devices, et cetera. Also includes, any, abscesses that you may have identified. When I was doing my ID rotation earlier this year, we had another IVDU who injected through the right groin, had this presented with this, with MSSA bacteremia and this massive abscess in the right groin. That needs to be drained by vascular for source control, because you could be throwing antibiotics at the patient, but if the patient's abscess isn't dealt with, the patient will be continuously seeding bacteria into the blood, no matter how much antibiotics you throw at the patient. And this also includes things like pacemakers, other prosthetic material like total knee a knee replacement, if there's metal wear in the spine, etc., that may need to be taken out if it's a potential infective source. Now, so that's source control. Often you need to involve surgical teams for that. But talking about antibiotics, which is, I guess, your bread and butter on as the ID doctor. As soon as you find out that your patient has Staph aureus bacteremia, you need to commence empiric antibiotics straight away. And of course, after you collected at least 2 sets of blood cultures, but as quickly as possible because of the mortality risk of Staph aureus bacteremia. Now, generally, Staph aureus can be divided into 2 or 3 types. So people know about methicillin sensitive Staph aureus and versus methicillin resistant Staph aureus. Some labs also have this concept of penicillin sensitive Staph aureus, which are sensitive to benzyl penicillin, which we can potentially treat with IV benzyl penicillin rather than Fluclox, cefazolin, or vancomycin that we use for MSSA and MRSA. So essentially, yeah, 3 types. So penicillin sensitive Staph aureus, so PSSA, which are sensitive to benzyl penicillin. Methicillin sensitive Staph aureus, MSSA, which are resistant to benzyl penicillin but sensitive to methicillin and derivatives thereof, including Fluclox and cefazolin, etc. And the third one is methicillin resistant Staph aureus, so MRSA, which are resistant to methicillin and derivatives thereof, which we need to treat with vancomycin. Now, a fun fact to know is that in Victoria, the rate of methicillin resistance amongst Staph aureus isolates is 20%, which means that so often the first thing that comes back is that the lab has cultured Staph aureus in the blood, and that will be flagged as positive. And the lab, if it's really Staph aureus bacteremia, the lab really should call you as the doctor taking care of the patient, and they'll be like, oh, hey, we've cultured Staph aureus in the aerobic bottle of the culture taken yesterday. We're not sure whether it's methicillin sensitive or methicillin resistant at the moment. We're running that test, and we'll update the result when we find out. Often this can take a day for them to ascertain whether it's MRSA or MSSA. At Royal Melbourne, we have some new technology apparently that allows us to find out whether Staph aureus is MSSA or MRSA within hours, which is quite nice. But in any case, as soon as a patient is flagged to be bacteremic of Staph aureus, you should really commence patients on both MSSA antibiotic therapy and MRSA antibiotic therapy, because 20% of isolates are MRSA. You don't want to be just treating with MSSA therapy and then find out a day later that the Staph aureus is actually resistant to MSSA therapy, and that you should have treated with vancomycin, because the patient probably would be dead. So MSSA we treat with two antibiotics, flucloxacillin and cefazolin, and different clinicians has different preferences, and we'll talk about the benefits and the risks associated with each. MRSA we treat almost universally with vancomycin unless the patient is allergic to vancomycin for whatever reason. Now, just before I talk further about these antibiotics, can someone remind us what makes MRSA MRSA? As in, what is the difference, genetically speaking, between MSSA and MRSA? What's so special about MRSA that makes them able to resist killing by methicillin derivative antibiotics? Yeah. So beta-lactam resistance. Do you guys know why? Yeah, fantastic. Yeah. Josh, do you remember the name of the penicillin binding protein that that MRSA uses instead of the usual penicillin binding protein? That's all right. So just for everyone else, so bacteria such as Staph aureus synthesize their peptidoglycan layer of their cell wall in little blocks that then get sort of flipped out onto the outer aspect of the plasma membrane and connected to this growing peptidoglycan chain. And they do that using a protein called penicillin binding protein. A peptidoglycan building block is synthesized in the cytoplasm of the bacteria. Then it gets transported to the plasma membrane and then gets flipped out onto the external aspect of the cytoplasmic membrane. And then you have this penicillin binding protein that then takes that peptidoglycan building block and connects it to the growing peptidoglycan chain. And that occurs until the bacteria synthesizes its entire peptidoglycan layer. So beta-lactams, like penicillins, cephalosporins, et cetera, they work by binding to the penicillin binding protein and preventing them from, connecting the newly synthesized peptidoglycan building block to the growing peptidoglycan chain. But MRSA gets around this by having a gene called the MECA gene, so MECA, so MECA gene, which encodes this altered penicillin binding protein called penicillin binding protein 2A, so PBP2A, which is not recognized by beta-lactam antibiotics and so evades inhibition by beta-lactam antibiotics. So it's structured, kind of differently, that the beta-lactam antibiotics, no matter how much beta-lactam antibiotic you throw at the bacteria, the beta-lactam doesn't recognize this new penicillin binding protein, and so the MRSA can continue sort of connecting newly synthesized peptidoglycan building blocks to the growing peptidoglycan chain. So actually, my understanding is that at Royal Melbourne, they actually run a PCR to detect the presence of the MECA gene, which is why they can usually tell us whether a Staph aureus isolate has that MECA gene, in which case it's MRSA, or doesn't, in which case it's MSSA within hours after they actually culture the Staph aureus. So anyway, once you start the patient. So a patient comes to you, bacteremic or Staph aureus. You commence IV Fluclox or IV cefazolin to cover for MSSA, plus IV vancomycin to cover for MRSA as well. And then usually you need to wait a couple of hours to a day for the sensitivities to come back. And once the sensitivities come back, that you can sort of switch the patient to more directed therapy. Now, if the lab has reported the Staph aureus as a PSSA, then often you can just switch the patient onto benzyl penicillin. But I've actually never seen that happen. There's nearly always you'll be told to ring the medical microbiologist in the lab before placing the patient to just IV benzyl penicillin for treatment of PSSA to confirm that it's actually PSSA. But for MSSA, the directed therapy is either IV Fluclox or IV cefazolin, and they're really interchangeable antibiotics. Does anyone know why in what clinical scenario might we use Fluclox over cefazolin?
Is it just the times you give it for nursing staff?
So that's actually a good point. So as you can probably appreciate from the cefazolin is given Q6 hourly to 8 hourly, and Fluclox is given more frequently. So actually dosing, so IV Fluclox is actually not that. So you need to, if a patient is on IV Fluclox Q4 hourly, that literally means you need to, the nurses have to administer it to the patient 6 times every day. And that's sometimes quite burdensome. And the reason for that is, so cefazolin has a longer half-life than Fluclox. So if you don't, if you're in a situation where, administering IV antibiotics 6 times a day isn't really an option for you, then yeah, potentially cefazolin is a more convenient antibiotic to place a patient on, purely because it has a longer half-life. So that's actually one reason, for placing a patient on cefazolin rather than Fluclox. But how about the other way around? So when might we consider Fluclox over cefazolin? So osteomyelitis, not really a reason for Fluclox over cefazolin. So there's actually this really a scientific concept called the cefazolin inoculum effect, and you can Google this. So cefazolin inoculum effect. It's basically in the lab they've observed that when you have a high burden of Staph aureus, Fluclox actually does a much more effective job at clearing the bacteria than IV cefazolin. So in high inoculum disease, often you might prefer Fluclox over cefazolin. Say, for instance, the patient has 4 or 5 consecutive blood cultures flag positive for Staph aureus. You might suspect then, okay, the patient has quite a bit of Staph aureus on board in the blood. Potentially Fluclox will be better at clearing the blood of this high inoculum disease. So that's one reason for choosing Fluclox over cefazolin. From my reading, that hasn't actually been, that's a lab finding. The inoculum effect is a lab finding. That hasn't actually been borne out in clinical trials. In clinical trials, they've actually found cefazolin to be non-inferior, or if not better, than flucloxacillin. So it's really, whether you believe in the lab findings or the clinical studies that have been done comparing Fluclox to cefazolin. Now, that's actually the only reason that I can think of for putting patients on Fluclox rather than cefazolin. There are actually a lot of reasons why you might want to choose cefazolin over Fluclox, and one of the reasons has already been mentioned, which is I guess high. So a longer half-life. Cefazolin has a longer half-life, and so it doesn't need to be administered as frequently. The other reasons include, so cefazolin is not as hard on the liver and is not as hard on the kidneys. So if a patient has liver disease or liver failure, as our patient does, or if the patient has bad kidneys, often cefazolin is better than Fluclox. Fluclox has been associated with AIN, so interstitial nephritis, and is quite toxic to the kidneys. So cefazolin is a little gentler on the kidneys and the liver. The other reason is an economic reason. Cefazolin is much cheaper than Fluclox. So depending on which consultant you work with, they'll have a preference either way. But as you can probably see, I probably lean towards cefazolin because of the side effect profile of Fluclox. Anyway, so that's MSSA, and MRSA we treat using IV vanc is first line. Important for you guys to know that actually vanc is not so good for MSSA. So don't think of this as like vanc is more powerful than Fluclox or cefazolin. Vanc is actually that bad for MSSA, and it's been shown that vanc is an independent risk factor for treatment failure in MSSA bacteremia. So you really shouldn't be treating patients with MSSA bacteremia with VANC, unless the patient has clearly demonstrated a severe beta-lactam allergy, in which case you can't use any of the beta-lactam antibiotics. You have to go for something like VANC. So I got questions. So explain the difference between PSSA and MSSA. So yeah, it's a bit of a misnomer, but I guess by penicillins, they mean things like benzoyl penicillin. Flucloxacillin is a penicillin as well. But in the name PSSA, I think they're specifically trying to say whether the Staph aureus isolate is benzoyl penicillin sensitive or not. And is cefazolin the go-to for many orthopedic procedures? That sounds like a surgical problem, a surgical question. I'm probably not the best person to ask about that, but potentially, as we've alluded to this lecture, often Staph aureus infects prosthetic joints and hips and whatever. And so it makes sense for cefazolin to be used in that setting. Anyway, this is the patient's TTE. I'm not sure how whether it's too blurry to actually read the conclusion. So our patient actually had a TTE as her initial study, and that actually showed mitral and tricuspid valve endocarditis with moderate to severe mitral regurgitation and severe tricuspid regurgitation. So when a TTE flags positive for a vegetation, you don't really need a follow-up tow, right? You know that the patient has a vegetation, and you treat it as such. But it's important to bear in mind again, TTE you cannot rule out infective endocarditis using a TTE. So if you have a patient that's bacteremic of Staph aureus, and you're a TTE and it comes back negative, you often still need to order a tow. To definitively rule out infective endocarditis. And as we will discover shortly, you can actually diagnose infective endocarditis even if the tow tells you that doesn't show any vegetations, and we'll see why. So a couple of words on infective endocarditis. So as the name suggests, it's infection of the endocardial surface of the heart. So usually refers to heart valves. The infection usually reaches the heart valve via the bloodstream. So quite unusual for a patient to have infective endocarditis without having bacteremia. But Staph aureus is not the only bacteria that can cause infective endocarditis, as we'll discuss later on. Sometimes infective endocarditis can emerge in an otherwise healthy patient, but there are some things that place patients at higher risk of developing infective endocarditis, and that includes a prior history of infective endocarditis, prior history of valvular or congenital heart disease, active IVDU, as we have in our case, indwelling IVCs, patients immunosuppressed for whatever reason on pred for rheumatoid arthritis, on azathioprine for SLE, et cetera, had a recent dental or surgical procedure. All of these predispose a patient to infective endocarditis. As you guys probably are already aware, infective endocarditis typically presents with some pretty non-specific symptoms. Usually, fever. Almost all patients have a fever, but patients might also complain of, that they're off their foods, weight loss, tooth pain. If the infective endocarditis is coming from the tooth. Signs, on examination, you might hear a new murmur. And especially new mitral regurgitation or new tricuspid regurgitation. Can someone remind me, mitral regurgitation, what does that sound like? Like what kind of murmur is that? Pansystolic characteristics. So I wouldn't call it ejection systolic. That's usually reserved for aortic stenosis. But yeah, a pansystolic murmur, usually heard best at the apex in the mitral area, often radiates to the axilla. And because the mitral valve is left-sided, it's louder on expiration. Tricuspid regurgitation is the second most common, murmur that you'll find in infective endocarditis. And can someone remind me what tricuspid regurgitation sounds like? It's also a pansystolic murmur. Yep. Usually heard loudest in the lower left sternal edge. Around where the tricuspid area is. Because the tricuspid valve is right-sided, it's louder on inspiration. And it's often associated with V waves in the JVP. I'm not sure whether you guys have actually seen, V waves. Sometimes, in patients with, severe pulmonary hypertension with a RVSP of 56 would have very clear, V waves and functional tricuspid regurgitation. The other thing that you might find is a pulsatile liver that's commonly associated with a tricuspid regurgitation. And on examination, you might also find, the 4 infective stigmata of infective endocarditis. So splinter hemorrhages, Janeway lesions, Osler nodes, Ross spots, et cetera, et cetera. Now, we've talked about one organism that can cause infective endocarditis. There are 4 other, so there are in total 5 typical organisms that cause infective endocarditis. We've mentioned Staph aureus. What are the other ones? Viridans strep, yep. From dental infections. Enterococci, yep. I've actually mentioned all of them during this talk at some point. Hackek, good. So that's, Staph aureus, strep viridans, enterococci, hackek, one more. Strep bovis, the one that's associated with colorectal cancer. So yeah, Staph aureus is the most common cause of acute infective endocarditis. So onset, hours to days. Staph aureus usually affects healthy native valves. In contrast, viridans strep is the most common cause of subacute infective endocarditis that usually comes on, weeks to months. As Jason mentioned, commonly transmitted through dental procedures, and tends to affect damaged native valves or prosthetic valves rather than healthy native valves. Strep bovis, as I said, now it's called Strep gallolyticus. The thing that you need to remember, it causes, very rarely causes infective endocarditis. It's one of the 5 typical organisms. It's associated with colorectal cancer. So reflexively, you need to, if you culture strep bovis in blood cultures, you need to reflexively order a colonoscopy because this patient might have, I think 50% have colorectal cancer. So hackek organisms we've talked about causes 3% of IE cases, also associated with poor dental hygiene and periodontal infection. And enterococci, especially E. faecalis, the one that's sensitive to amoxicillin, can cause infective endocarditis and typically transmitted following a nosocomial UTI or some genitourinary procedure because it's a cause of UTI. Now, sometimes coagulase negative staph, so staph epidermidis can also cause infective endocarditis. It's more commonly a skin contaminant, but can be transmitted through, say, an infective peripheral cannula and cause infective endocarditis, commonly on prosthetic valves rather than healthy native valves. Just a question, which layer of fascia would a dental infection? That's hugely specific, and I don't know the answer to that, sorry. So, diagnosing infective endocarditis. So, the diagnosis of infective endocarditis should be suspected in any patient with bacteremia due to an organism known to cause infective endocarditis. So really the 5 typical organisms plus the one sort of, skin contaminant organism. So I call these the 6 sticky organisms. So these, when they're found in the blood, they like to stick to heart valves. So the diagnosis of infective endocarditis is made strictly based on modified Duke's criteria. And I don't know whether most of you guys should have sort of at least read about modified Duke's criteria in your studies so far. I think the way to remember Duke's criteria is that there are 2 major criteria and 5 minor criteria. So the 2 major criteria pertain to blood cultures and the echo. And if you think through, how you work through a patient with Staph aureus bacteremia, these are investigations that you'll reflexively order. Blood culture positivity for one of the 5 typical organisms causing infective endocarditis on at least 2 separate blood cultures taken, at least 12 hours apart, is one major criteria. The second major criteria is echocardiogram positivity for either a vegetation, so a lump of bacteria on say the mitral valve or the tricuspid valve, or on auscultation you demonstrate, or on echocardiogram you demonstrate new valvular regurgitation that the patient hasn't had premorbidly. So 2 major criteria: blood culture positivity and echo positivity for either vegetations or new valvular regurgitation. There are 5 minor criteria. So the first is, is the patient predisposed to having infective endocarditis? So is the patient an IVDU? Does the patient have predisposing heart conditions such as a prosthetic heart valve or a congenital heart condition, right? That's one minor criteria. Now, a fever, as I said, 90% of patients with infective endocarditis have a fever. So the patient is afebrile, like pretty much, you can rule out infective endocarditis because almost all patients are febrile. It has to be a proper fever, not like 37.6 or something. It needs to be, above 38. The third minor criteria is vascular phenomena. And this is where, our discussion of the difference between Janeway lesions and Osler nodes and Ross spots become important. So vascular phenomena mean, an infective valve throwing off bits of bacteria into the bloodstream and that embolizing somewhere. So it can be a major arterial emboli. I've seen Staph aureus bacteremia causing strokes and patients coming in, under a code stroke, and later found to be, bacteremic of Staph aureus. Septic pulmonary infarcts. If you throw off, a bit of bacteria into the lungs, that can cause PEs, but a septic PE. Mycotic aneurysms in the brain, intracerebral hemorrhages, conjunctival hemorrhages, and Janeway lesions. So if you throw off bits of bacteria into the distal extremities, that can cause Janeway lesions, which are typically non-painful. Fourth is immunologic phenomena. So this is not so much septic embolization, but immune complexes being formed in the blood and then depositing in an organ. So if it deposits in the skin, it's what we call Osler nodes, which are typically painful. If it deposits into the kidneys, then it can cause a GN, so glomerulonephritis. If it deposits in one of the retinal vessels, it can cause Ross spots, et cetera, et cetera. And then the last minor criteria is microbiological phenomena. So you can have positive blood cultures, but not quite meeting the strict criteria set out by major criteria number 1. Major criteria number 1 is specific for typical organisms. So 2 times blood cultures being positive for Staph epidermidis doesn't quite cut it. So you can't say you've met the first major criteria if you culture Staph epidermidis twice. That's a minor criteria. And so to diagnose definite IE, you need either 2 major criteria, 1 major plus 3 minor, or 5 minor criteria to diagnose definite IE. And then there's this nebulous, possible IE concept where if you meet 1 major and 1 minor criteria, you're in the possible category. And if you meet 3 minor criteria, then you also meet the possible category. Cool. So the last thing that I want to talk about before I move on to the next case, and I'm probably running a bit behind on time, but we'll try to wrap up on time. So a common consultant ward round question is, when do you need to consider a referral to cardiothoracics for valvular surgery in a patient with infective endocarditis? And I guess the answer to this depends on whether the infective endocarditis is left-sided or right-sided. So for patients with left-sided infective endocarditis causing, say, a new mitral regurgitation, there are 4 indications for referral for early valvular surgery. So firstly, infective endocarditis associated valvular dysfunction causing symptoms or signs of heart failure. So elevated JVP, peripheral edema, all those, shortness of breath, et cetera, all those are telltale signs that the patient has gone into acute decompensated heart failure, and that's often sufficient to get a cardiothoracic surgeon interested. The second is, as we mentioned, paravalvular extension of the infective endocarditis. So often this can cause heart block, which is evident on ECG. The third is a difficult to treat pathogen. So I've just talked about bacteria. So sometimes fungi can cause infective endocarditis, and that's typically difficult to treat. And there are also some multi-drug resistant organisms as well that will be part of that category. And that's also an indication for early valvular surgery. And the last is persistent infection, which is defined as persistent bacteremia or fever lasting more than a week after initiation of appropriate antibiotic therapy. Then it's obvious that your antibiotic isn't cutting it, there's probably too high a burden of Staph aureus in the blood. You probably need source control, which is to repair the valve. So for patients with right-sided infective endocarditis, there are also 4 indications for valvular surgery. So in right-sided infective endocarditis, size matters. So very large vegetations, more than 2 centimeters in diameter. Usually that's sufficient to get a cardiothoracic surgeon interested in operating. Recurrent septic PEs, highly resistant organisms, and persistent bacteremia are all indications for valvular surgery in right-sided infective endocarditis. So something to have up your sleeve if you're ever rotating through vids. It's a favorite on ward round. So just to consolidate some of that. So what are the 5 common sites of metastatic infection in Staph aureus bacteremia? And feel free to just drop the answer in the chat. And I guess you need to be able to think of this on the spot when you're asked to see, say a patient with Staph aureus bacteremia in ED, right? These are the things that you would specifically ask for on history and look for on examination. So commonly, the back, so joints and the back causing osteomyelitis, discitis, and epidural abscesses, the kidneys, the spleen, the brain, et cetera, as people have already mentioned. What is the difference between MSSA and MRSA? Well, MRSA has the MEK gene that encodes for an altered penicillin binding protein that's not recognized by beta-lactams, and so you need to treat MRSA using vancomycin rather than beta-lactams. What are the advantages of IV Fluclox over IV cefazolin? So this is, well, in the interest of time, I'll just say the answer. So the inoculum effect. So, theoretically, Fluclox is better for high burden disease, but the advantages of IV cefazolin over IV Fluclox are many. So it's cheaper. It has a longer half-life, so you don't need to give it as often. It's gentler on the kidneys. It's gentler on the liver. So we prefer it in patients with cirrhosis and kidney failure. 4 peripheral stigmata of IE, so Ross spots, Janeway lesions, Osler nodes, and splinter hemorrhages. 5 typical organisms that cause infective endocarditis. Staph aureus is one. Viridan strep, Strep bovis, Enterococcus, etc. What are the 2 major criteria for diagnosis of infective endocarditis? Blood cultures and echo. And the 5 minor criteria include, predisposing factors, fever, vascular phenomena, immunological phenomena, and microbiology that doesn't quite meet the major criteria. And you commonly need 2 major criteria, or 1 major, 3 minor, or 5 minor criteria to diagnose definite IE. And what additional investigation do you need to order for patients with IE caused by Strep bovis? I'll let you guys answer that one. Colonoscopy, fantastic. 4 indications for valvular surgery in left-sided native valve in infective endocarditis. So heart failure, paravalvular extension of infection, difficult to treat organism and persistent bacteremia. 4 indications for valvular surgery in right-sided native valve infective endocarditis, well, very large vegetation, so greater than 2 centimeters in diameter, recurrent septic PEs, highly resistant organisms, and persistent bacteremia as well. Moving on. So here is an 86-year-old female from Home Alone, admitted for workup of a right lung apex nodule found incidentally on a CT trauma brain facial bones cervical spine that was performed during a recent admission for a fall. Past medical history, a bit of cardiovascular risk factors, but nothing too fancy. On some blood pressure medications. Significantly born in Croatia, moved to Australia in the 1970s, hasn't lived elsewhere. From Home Alone, son and daughter-in-law visit quite often. Never smoked and doesn't really know her history of TB or exposure. So on chest X-ray, not sure. I've put an arrow there to try to make it more obvious, but there's a small focus of nodular infiltration in the region of the right upper lobe. So we would be very suspicious for TB in that in this setting, and I think we'll go through TB a bit. So tuberculosis is an infection caused by acid-fast bacilli called Mycobacterium tuberculosis, which typically affects the lungs. Now, based on cell wall structure, TB is technically a gram-positive organism, but it has this unusual waxy coating made up of mycolic acid that makes it impervious to gram staining. Which means that if you attempt to gram stain acid-fast bacilli or TB organism, it can appear either as gram-negative or gram-positive. So we don't use gram staining. Do you guys know what stain we typically use for TB? Yeah, Ziehl-Neelsen stain. Well done, Joel. So a bit about the natural history of TB. So you guys probably learnt this in your pre-clin years, but primary TB infection usually causes the formation of a granuloma, usually in the mid to lower lobes out in the periphery. So we call that a GON focus. So I've noted a GON focus there in purple. So granuloma is just a body's attempt to wall off the infection using macrophages and T cells. And it's a way to contain the TB organism just in the lungs and prevent it from spreading any further. The TB organism can sometimes spread even with the granuloma, can sometimes spread to the hilar lymph nodes, causing some hilar lymphadenopathy. And a GON focus plus hilar lymphadenopathy we call a GON complex. Now, following primary infection, 90% of patients heal by fibrosis. But about 10% of patients, and this is especially the case if the patient has, advanced HIV infection, has AIDS, or are malnourished, these patients can sometimes develop what we call progressive primary infection. So the TB organisms can't be contained by a granuloma, and the infection progress, causing TB bronchopneumonia. Then it seeds from there into the blood, causing TB bacteremia, and then it disseminates throughout the body, causing what we call miliary TB. And in miliary TB, the TB organism can seed into virtually any organ of the body. So, for the 90% of patients who heal by fibrosis, the TB organism usually remains latent in the body for many, many years, and they're kept in check, kept latent by the immune system of the host. But there's a 5 to 10% lifetime risk of the TB organism reactivating, and if the immune system becomes compromised in any way, reactivation can occur. And when reactivation occurs, we call this secondary infection. And in secondary infection, it's similar to primary infection, except that the reactivated granulomas tend to present in the apices of the lungs, or in the upper lobes of the lungs, presumably because there's more oxygen up there. But lymphadenopathy is quite uncommon in reactivated TB or secondary TB. From secondary infection, some patients can develop progressive secondary infection, so manifesting firstly as TB bronchopneumonia, in which the granulomas cavitate due to central caseous necrosis, and then the bacteria seeds from there into the bloodstream, causing TB, bacteremia, and then from there miliary TB. But I have a picture there of what progressive secondary TB might look like. So the diagnosis of TB is suspected in patients with relative clinical features and relevant clinical features and relevant epidemiological risk factors. So what I mean by relevant clinical features is, cough lasting more than 2 to 3 weeks, having lymphadenopathy noted and an unclear cause identified, and constitutional symptoms like fevers, night sweats, weight loss, all point towards a diagnosis of pulmonary TB. But then you need to couple that with relevant epidemiological risk factors. So, I mean, if a patient has was born in Australia and has been in Australia all their life, the risk of TB is actually really, really low, unless they have been exposed to someone who has come from overseas. So you need to couple, clinical features with the epidemiological risk factors that the patient has. Now, the approach to diagnosing TB is fairly algorithmic, and I don't know whether you guys have seen any TB patients on the ward, or have seen any patients being worked up for TB. So the first step, as with anything, take a history, perform an exam, and then based on history and exam, you'll be able to pick out, the relevant, whether the patient has the relevant clinical features of TB, whether the patient has the relevant epidemiological risk factors for TB. If you suspect TB based on the history and the exam, then you'll order a chest X-ray. And that screenshot of the chest X-ray that I showed just before is quite typical for secondary TB, so reactivated TB, which classically presents with focal infiltration in the upper lobe. The disease can be unilateral or bilateral. In this case, it was unilateral. And if the patient has progressive secondary TB, which often occurs in immunosuppressed patients, cavitation can also be seen on chest X-ray. Now, if the chest X-ray makes you suspicious for TB, then the next step is to collect 3 sputum specimens that are at least 8 hours apart, and that includes at least 1 early morning sputum, which has greater sensitivity. Now, so do you guys know how the sputum is collected? So obviously, if the patient has a good going productive cough and can cough into the the sputum cup that we provide to patients, then that's ideal. But what do we do with patients who don't have a good going cough? Do you guys know of any methods that we can? Yeah, terrific. Yeah. Josh is on the money there. So it can be induced. The sputum can be induced. So often, if the patient has difficulty, producing sputum, then sputum can be induced by inhalation of aerosolized hypertonic saline generated by a nebulizer. What if that's unsuccessful? What other strategies do we have to collect? Yeah, lavage, fantastic. Yeah, so bronchoscopy, and you would need to so in ID you talk to respiratory a lot because all TB patients with suspected TB that don't have a good going cough and where induced sputum samples cannot be achieved need a rest referral for bronchoscopy. Bronchoscopy will perform what we call a bronchoalveolar lavage, or BAL, and we can collect the sputum sample that way. Now then so once we've obtained the sputum the 3 sputum specimens, we then submit them for 3 separate tests. Acid-fast bacilli smear, and what this is basically they they prepare a Zeal-Nielsen stained sputum smear, and then they have a look down the microscope. So it's actually AFB smears, get reported the quickest because it just involves looking down the microscope and the person reporting what they see. So it's the most rapid, it's the most inexpensive diagnostic tool for TB. But the thing that you need to remember is that this is an AFB smear. So Zeal-Nielsen stains all acid-fast bacilli. So this includes all mycobacteria, not just Mycobacterium tuberculosis. So I'll mention some non-tuberculous mycobacteria a little later, but it picks up. So AFB smear cannot distinguish between TB and non-TB mycobacteria. So in this sense, it's not very sensitive for TB specifically. And really the smear is only positive if there's high organism burden. From my experience, often the smear is negative, in which case, we can't rule out TB. It's just that if the patient has TB, then the organism burden actually not that high. So AFB smear, that's the quickest, gets reported within a couple of hours. The next test is PCR, or what is sometimes referred to as a gene expert testing. So they run the PCR to identify the TB organism. So this is much more sensitive than the AFB smear, and can tell the difference between Mycobacterium tuberculosis and non-TB mycobacteria. The result usually takes about 24 to 48 hours to get back. And sometimes, and certainly at Royal Melbourne, the gene expert testing tells you whether it's TB or not. And also, if it is TB, tells you whether it's rifampicin resistant or not. And that can help you then that will guide what therapy you place the patients on. The slowest, and this takes forever to come back, is mycobacterial culture. But this is the most sensitive and it's the gold standard for diagnosis of TB. Now, there are 3 types of culture media that can be used. Some of them aren't really used that much anymore. So there's the egg-based culture media called the Lowenstein-Jensen, which I guess sometimes you hear about in textbooks, but it's not really performed these days anymore. There's also the agar-based media and also the liquid broth, what we call MIGIT, so MIGIT. Growth in the liquid media occurs much faster, and so the result will come back in 1 to 3 weeks. Growth in solid media a little slower, usually takes 3 to 8 weeks to come back, but usually they all culture in both liquid media and solid media. Once growth is detected in either media, they'll report it. And then reflexively, they will then forward it to the reference lab for species identification and drug susceptibility testing. Now, so because the mycobacterial culture takes forever to come back, right? We don't really wait until the culture results come back before initiating treatment. So actually, if you have a patient who is smear positive and PCR positive, that's actually enough to diagnose pulmonary TB and to commence the patient on treatment. Now, I want to ask you guys, what's the standard treatment for TB? Great. What do you mean by RIPE? So what are the 4 drugs in RIPE? Rifampicin, isoniazid, ethambutol, and pyrazinamide. Fantastic. And the usual treatment is, for the first 2 months, you give all 4 agents. And then for the next 4 months, you drop the last 2 and you just continue the patient on rifampicin and isoniazid. So we, as I guess medical students, often remember this as RIPE. Actually, it's not called RIPE on the ward. It's referred to as HRZE therapy. And H actually stands for isoniazid, God knows why. And R stands for rifampicin, Z stands for pyrazinamide, and E stands for ethambutol. So HRZE therapy. Now, for extra points, who remembers the side effect of rifampicin? Red secretions, fantastic. Who remembers the side effect of isoniazid? Peripheral, yeah. And that's caused by, and this is clinically relevant, the peripheral neuropathy is actually caused by a functional vitamin B6 deficiency. And vitamin B6 has a different name called pyridoxine. So often when we place patients on isoniazid therapy, we would also supplement with vitamin B6. So often the treatment is not called RIPE, it's called HRZE plus B6. And what that's referring to is we're trying to prevent functional pyridoxine deficiency by supplementing B6 when we're placing a patient on isoniazid. And ethambutol. Actually, let's go in order. Pyrazinamide. What's the side effect of pyrazinamide? Yep, sure. It's also hepatotoxic. And ethambutol. Yep. So red-green color blindness usually. So I've summarized that all here and have sort of listed their mechanisms of action. I think more clinically relevant is really the side effect profile of each of these agents, because after you diagnose TB, one thing that you need to do as a junior doctor is counsel the patient on the possible side effects that they will experience on HRZE therapy. So important to bear in mind all these possible side effects. A quick word about non-TB mycobacteria. So Mycobacterium tuberculosis is not the only mycobacteria in existence. So how I think about mycobacteria is dividing it into Mycobacterium tuberculosis and Mycobacterium leprae, which causes leprosy. And remember last week we talked about how we treat leprosy using dapsone. It's one of the 3 indications for dapsone. And then we have this third category of non-tuberculous mycobacterial, NTM, and we tend to divide it into rapidly growing mycobacteria and slowly growing mycobacteria. And the clinically significant ones are, so rapidly growing, I tend to remember using the acronym FACS, so Fortuatum versus cheloni, but you will see, especially if you do an ID rotation at a hospital like Peter Mac, for instance, where a lot of patients are severely immunosuppressed from the chemotherapy, you will see a lot of slow-growing non-TB mycobacteria, including Mycobacterium avium complex, MAC, and also, if you live in Brunswick, Mycobacterium ulcerans, which causes that Buruli ulcer. And apparently there's an endemic recently in Brunswick. And actually in a patient presenting with a new sort of lung nodule for investigation and it's query TB, if you find that epidemiologically the patient was born in Australia, has never been exposed to anyone with a history of TB, but is smear positive, chances are the AFB that was identified on smear is actually a slow-growing non-tuberculous mycobacteria on balance of probability, because you don't really see TB here in Australia. So it's more likely to be a Mycobacterium avium complex, for instance. Cool. So a few quick questions. Characteristics of primary pulmonary TB. So I guess you form that GON focus, hilar lymphadenopathy, and then you form the GON complex. So, and from there, if you're immunosuppressed, you can develop a progressive primary infection, which results in TB bronchopneumonia, then TB bacteremia, and then TB miliary TB, where it's disseminated. The characteristics of secondary pulmonary TB. So reactivated TB or secondary TB likes the apices of the lungs. So you will still see the same sort of granulomas being formed, but they have a predilection for the upper lobes rather than the middle or lower lobes. The three tests that we run on sputum, how do we collect sputum? Well, ideally, the patient coughing it up. If not, we can induce it using hypertonic saline. If not, we can do a bronchoscopy and do a bronchoalveolar lavage. Which three tests do we run on sputum specimens? The quickest one is AFB smear, but that's not sensitive to TB. You'll see any acid-fast bacilli, even non-TB mycobacteria. That takes a couple of hours to come back. And then the second one that comes back is the gene expert. So PCR that is sensitive to TB. It will tell you whether the acid-fast bacilli that you've identified on smear, whether that's actually TB or not. At most hospitals, I think they'll give you whether it's rifampicin resistant or not. And then the third one, which takes weeks to come back, is the culture. The thing that you need to remember is we don't wait for the culture results to diagnose TB, although that is the gold standard. Smear positivity and PCR positivity is sufficient for the diagnosis of TB and for us to commence therapy. And how do we treat TB? HRZE plus B6 and the side effects we've just talked about, and classification we also just talked about as well. So quickly, last case, and sorry, I'm running a little over time. So the last patient we're going to talk about is this 55-year-old male, and I've switched this to 4 South. At Royal Melbourne, the level 9 is the infectious diseases ward. 4 South is the neurosurgery surgery ward, and this is pertinent to this case. It's a 55-year-old male transferred from an external hospital with multiple rim-enhancing brain lesions and India ink stain positivity on CSF in the setting of acute onset psychosis and behavioral disturbance, and also a new lung lesion. Oh, fantastic, Josh. Yes. So I was going to ask, what's India ink stain positivity? That's quite specific for Cryptococcus. So, you know, patient doesn't have much by way of past medical history, is on some antidepressants, from home alone, usually independent with all his ADLs, but has come in with this acute psychosis and found at an external hospital to have these lesions in the brain and a lesion in the lung. Bloods, yeah, hemoglobin is okay. Neutrophils a little elevated, but you know, not too interesting. UECs, you know, they're a bit hypokalemic, but you know, that's neither here nor there. You'll just give some, you know, chlorvescent for that. CRP is 100, probably can't be ignored. You know, there's probably inflammatory / infective process happening here. You know, we didn't really want to reinvent the wheel. We hub and spoked across some of the images from the external hospital, but we did perform a chest X-ray because it's easy to do. And what I want to draw your attention to is this little area of consolidation in the left lower lobe. Otherwise, you know, the lungs are clear, but this is quite concerning. Now, you know, we hub and spoked across the images from the external hospital. They did a CT brain first, showed no hydrocephalus, but 2 small low density foci in the frontal lobes, no other lesions within the limits of a non-con study. MRI brain showed findings that were in keeping with meningitis and ventriculitis. Multiple intraparenchymal enhancing, these rim enhancing lesions that point towards a diagnosis of cryptococcus. So well done, Josh, for picking that up. So a brief word on cryptococcus. So there are 2 main. So cryptococcus is a fungus. It's an invasive fungal infection caused by a fungus called cryptococcus. And cryptococcus is famous for having this polysaccharide capsule that can be visualized on application of Indian ink stain. So the fact that it stains positive on Indian ink stain is quite specific for cryptococcus. Now, there are 2 main species of cryptococcus, neoformans and gattii. And I think the one that you probably have heard of is Cryptococcus neoformans, which is the principal pathogenic member of this genus. Now, most patients infected with Cryptococcus neoformans are immunocompromised, and in decreasing, you know, frequency, you know, the immunocompromise is due to, you know, AIDS, you know, prolonged treatment with glucocorticoids, organ transplantation, malignancy, liver disease, and sarcoidosis. Now, Cryptococcus is found worldwide, and it's usually found in the soil of areas frequented by birds, especially pigeons and chickens. And this is quite quite different from I guess where you would find the other species of Cryptococcus, Cryptococcus gattii. And it's important to know the difference between neoformans and gattii, because gattii are usually infect immunocompetent patients. And this gentleman, you know, this patient that we're seeing, he has no sort of, you know, his past medical history is only really significant for severe depression. It has no other medical comorbidities, is not immunosuppressed. Usually we'll be thinking, you know, even if we were suspecting Cryptococcus, usually we would be thinking more gattii rather than neoformans in the context of immunocompetence. Whereas neoformans has a worldwide distribution, gattii is really only found in the tropics and subtropics, and it's quite specific to Australia and New Zealand. It's not really found in other parts of the world, and it's found. So neoformans, we said, was found in the soil of areas frequented by birds. Gattii is found in eucalyptus trees, red gum trees. And you would often find, ID physicians asking, wild questions on history about, possible, sites of exposure. One thing that, if you're suspecting Cryptococcus that you should ask for is, have you been exposed to soil that are frequented by birds? In which case, you'll be thinking more near foreman's. The other thing is, have you been working with red gum trees? The thing to know is that Cryptococcus, so both Neoformans and Gattii, they have a tendency to affect two organs in particular, so the brain and lungs. So in the brain, they can cause meningitis, meningoencephalitis. They can also cause these cryptococcomas, which are just big lumps of fungus. And I think another point of difference between Cryptococcus gattii is that Gattii has a much greater tendency to form large cryptococcomas compared to Neoformans. So Neoformans, you generally just see sort of meningitis and pulmonary infection. When you have these big lumps of Cryptococcus seen on imaging, you really should suspect Gattii, because Gattii have a far greater tendency to form these large cryptococcomas. So as I said, based on the fact that our patient is immunocompetent and likely has a large cryptococcoma in the lower lobe of the left lung, and also potentially multiple cryptococcomas in the brain as well. If we're suspecting cryptococcosis, it's most likely to be Gattii rather than a Neoformans. And if you ask specifically, and my consultant actually did this, the patient would have told you that he had recently been chopping red gum trees in his farm for firewood. So exposure to red gum trees is how you get Gattii, and it's usually inhaled. So a quick note about Gattii. So, acquired through inhalation, has an incubation period of around 6 to 7 months, which is why, often patients don't really draw the connection between exposure to red gum trees and then develop these psychotic symptoms 6 to 7 months down the track. As I said, infects the brain and the lungs. So, brain symptoms, headache, neck stiffness, or your meningitis symptoms can also cause seizures, especially in the context of, causing raised ICP, can cause a sixth nerve palsy and papilledema. Pulmonary disease, cough, dyspnea, chest pain are all possible symptoms. Complications, elevated ICP, it can also cause this immune reconstitution inflammatory syndrome. So this iris-like syndrome, which I won't go into, but you can read about. It's quite an interesting syndrome. And my patient actually did have suspected iris. The diagnostic workup usually includes some cerebral imaging. So this patient had a CT brain, MRI brain. This patient had a chest X-ray. Usually you'll follow that up with a contrast enhanced CT chest as well for better characterization. You can test for cryptococcal antigens on serum using a blood test, but for this patient, you really want to LP him because he's presenting with meningitis symptoms, and you'll analyze the CSF for cryptococcal antigen as well, and then you'll stain it using Indian ink stain to see whether it's positive, and then you'll culture it as well. So how do we treat Cryptococcus gattii? Three antifungal agents that are used: amphotericin B, flucytosine, and fluconazole. So the thing to remember about amphotericin B, it is a very dirty medication. Causes a number of quite significant side effects. So it can cause this drug-induced sort of fevers and chills. Can make patients hypertensive. It's quite toxic to the kidneys. Can precipitate arrhythmias, So often when you start patients on amphotericin B, you need to prophylactically supplement potassium and magnesium. Can cause anemia and also phlebitis as well. Flucytosine. Do you guys know the main side effect for flucytosine? It's one of the many drugs, including Bactrim, that can cause bone marrow suppression. Fluconazole is a fungal CYP450 enzyme sort of inhibitor, and so sometimes it can cross-react with human CYP450 and cause some liver dysfunction as well. So flucytosine, remember, bone marrow suppression, and fluconazole, or really all azoles, think about liver dysfunction. Now, for meningoencephalitis, we often have a protracted course of treatment. 3 stages. First stage we need to treat with IV amphotericin B plus oral flucytosine for up to 6 weeks. We generally do a repeat LP 2 weeks after induction therapy to assess response. If the response is adequate, then we move to the second stage, which is consolidation, which is on a high dose of fluconazole. But we need to monitor the liver, as I said, for possible sort of liver LFT derangements while on fluconazole therapy. And then that usually lasts for 8 weeks to prevent relapse. And then we place patients on a 1-year course of low dose fluconazole to really eradicate the infection. Lung infections don't require such an intensive treatment, but use much the same drugs. So I guess things to take away from this third section: 2 main species of Cryptococcus, Neoformans gattii, Neoformans in immunocompromised patients, gattii in immunocompetent patients. Gattii, so both infect the brain and the lung, but gattii has a greater propensity to cause these large cryptococcomas. So when you see them, you would think gattii rather than Neoformans. How is cryptococcosis acquired? By inhalation, and this can be inhalation of soil in the case of Neoformans that are frequented by these birds. But in the case of gattii, inhalation of fungi from red gum trees. Geographical distribution, so Neoformans is found worldwide, whereas gattii is really only found in tropical regions, so Australia and New Zealand. So how is meningoencephalitis treated? Well, we just talked about the 3 stages. So IV amphotericin and flucytosine, and then you step down to, if the response to that is adequate, then you step down to high dose fluconazole, and then a period of maintenance low dose fluconazole for a year. And the side effects, I think that the main side effects that you need to remember are flucytosine causes bone marrow suppression, whereas fluconazole causes hepatotoxicity, which is why you need to monitor LFTs throughout the consolidation and maintenance phases. So apologies for running over time, but that brings us to the end of the second virtual ward round. So thanks everyone for jumping on and also contributing your thoughts to the discussion. I think this always works a lot better when there's a bit of interaction going on. So just a bit of an ad for the next virtual ward round series in 2 weeks' time, same time, same day of the week. It will be in emergency medicine. So we'll talk about some common clinical scenarios that you might find when you're rotating through ED. So great. Thanks everyone, and have a good rest of the evening.